Hello everyone. We are back on again. We're going to talk about today a brief video on post-traumatic stress disorder. This is Comprehensive Psychiatry, which is our channel, and Dr. Imran Akram. I'm here with you today. We just goal today with a brief description of this very important topic. We're not going to be able to encompass everything. It's a very detailed topic, but my goal is that just so we can get some understanding and we can help people recognize some of the symptoms and go to their doctors and present it and also seek help. And they can also identify in some other friends or loved ones who might be suffering from this disorder for quite some time. So anyhow, PTSD stands for post-traumatic stress disorder. Now, it happens in people who are exposed to trauma, and that trauma can vary. It could be an accident, could be a war zone, could be anything. A trauma could be a sibling or a friend looking at another friend or observing another friend who might be undergoing a traumatic event. So observing it can also put you at risk of PTSD symptoms. Now, the onset varies. Sometimes it's within 1 month of the traumatic event. It can last for 6 months, sometimes a year or longer. But then sometimes there is a delayed onset. So you may not see anything right away. It might not present itself for almost a year. And then it presents itself. Sometimes we see that there are re-triggering events that people get exposed to. We can touch upon it a little bit later. Those can re-trigger and then resurface some of these symptoms. Very important is any disorder, it has to have a functional impairment with it. So if you're not functionally impaired, if it's not affecting your functioning, if you're a teacher, it's going to affect your teaching. If you're a student, it can affect your studies. When you're going to work, it can affect any part of your life that has to do with the functional element will get affected and disrupted. That's when we call it a disorder. Now, the risk factors vary, and you might say, why there are some people who get exposed to trauma, but then they don't get these symptoms, whereas others, they might get exposed one time and they have these symptoms of chronically forever. And it depends on a lot of things. It depends on at what age they were exposed, young age, repeated exposure, also history of depression, anxiety, mental health as mental disorders. Mental disorder history in the family will also can put you at risk. The environment, the stressful environment you're living in, even preceding the event can put you at risk. And then subsequently, what you're going through, all these things can put you at risk, and sometimes there is a cumulative effect of different kind of traumas that can lead to eventually presentation of these symptoms. Something we call it complex PTSD. This is basically repeated exposure to multiple traumas can present as a complex picture, and we call it complex PTSD. Not used by physicians. We don't use it very much, but it is used a lot more in counseling, the term, but it does exist, and it can be a little more tricky when it comes to the treatment. The presentation, the symptoms also vary depending upon what someone is exposed to. But generally speaking, people will say they have nightmares, waking up at night. During the day, they could have flashbacks of the event. And then sometimes people find themselves having dissociated symptoms, like they might be disconnected from the environment, or sometimes they're disconnected from their own feelings. Sometimes it could be almost a presentation like someone has psychosis or schizophrenia, and only the history can help us, and the onset. All these things help us differentiate what a person might have gone through and what their diagnosis could be. Sometimes they may have hallucinations, tactile, auditory, visual, but tactile can be depending upon the trauma, where the trauma is, and they may have strange kind of sensations, and we see all those things in the hospital or in the clinic. And we treat them accordingly. Some people, this is very common, the hypervigilance, or the startle response. Like, you might see someone who's been attacked or abused or sexually abused, and walking down the street, they might be anxious, they might be looking over their shoulder, and a friend of them might come and put their hand on the shoulder, and you will see this person jumping. So that's a startle response. They're always hyper vigilant, and that is because of what they've gone through in their life. They're not paranoid. So it's not a false belief. It's a belief that stemmed from a true trigger, true event in the past. And the brain obsesses and ruminates over these things because it doesn't want to get caught off guard in future again. So it's always anxious, always worried. A lot of intrusive memories. If the people are not treated, then they have to live through this day in and day out. And that's why it's very important that we get it diagnosed and treated appropriately and early enough. Many times we'll see people that have avoidance behavior. They will avoid a lot of social situations. They will avoid situations which is like, dark areas, dark alleys, noisy areas. They might avoid certain news channels. They may, of course, can avoid family gatherings because the perpetrator could be a distant family member or a close one or a friend who, it could be anyone. And then, we see along with these symptoms of PTSD, depression and depressive symptoms can start to trickle in. Anxiety symptoms can come all along, a lot of OCD symptoms, and that's where the counselors and the doctors have to be very careful not to overlook those symptoms. In children who are very young, 6 years or younger, you will see them waking up at night, sometimes regressing, bedwetting, but a lot of dreams and nightmares. You will see sometimes them reenacting the traumatic event, and you will wonder why this child is doing something like that. And counselors can shed a lot more light on it, like what the children do that can alarm you as to what they may have gone through if they've been sexually abused or molested or something. And I don't want to go into too many details today, but the counselors can really dive deep into it and can help you a lot more as to why someone is behaving in a certain way. One very important thing that we learn many times, when people are in the midst of a traumatic situation like war zone and stuff, and we see like why sometimes they don't present these symptoms right away, is because God has given us this protective mechanism, the adrenergic system, like we call it. Someone has a lot of adrenaline and the flight or fright response, so they're trying to protect themselves and move away from the trauma or the, if we can use the war zone, just to protect themselves. So at the time, the whole effort is there to protect themselves, their loved ones. Once they get to a safe situation, things settle down, the dust is settled now, we start seeing then the symptoms start to surface and start the presentation and all that. But while they're in the midst of that chaos, you may not see anything. And like I said, the triggers we talked about before, the discussions, the noise, seeing the perpetrator, TV channels, dark areas, all these things can re-trigger the symptoms. And we talked about the symptom presentation that could start from PTSD symptoms, can become very similar to psychotic symptoms, anxiety and depressive symptoms. The treatment, very interesting. We see the counselors, the experts in PTSD, they will do psychotherapy, cognitive therapy, where we understand the trauma and how to learn coping skills, exposure therapy, where you are gradually exposed to certain traumas, and then your reactions is what the counselor will work on to tame them down. It's a long chronic treatment. And then there is EMDR, which is eye movement desensitization reprocessing therapy. What I want you to take home is, if you are doing therapy on weekly basis and you feel that it is actually making things worse and you are unable to discuss this same trauma on weekly basis, do let your counselor know. Do let your therapists know that you actually have these symptoms in between appointments, and you dread coming to appointments sometimes because of what is being discussed. So the counselor then sometimes have to change directions. They sometimes have to take a breather and work on some other areas of your mood disorder, anxiety. But that's very important. Don't continue to do the trauma therapy if you're not ready for that. That's some of the very important things that we discuss with patients. We have to identify, is this patient really ready to dive into a deep therapy which could trigger and resurface some of the old memories and symptoms. Medication wise, people come to our clinic. Even in the hospital, we use a lot of antidepressants, serotonin medications. We use anti-anxiety medicines. We use medicines to help their sleep, and especially flashbacks or nightmares. The medication that is approved for that, we use that medication. But many times, like I talked about, some symptoms are very close, almost mimic psychotic symptoms like dissociation, disconnection from their surroundings, sometimes tactile hallucinations. So we do use small doses of antipsychotics, or sometimes obsessive thoughts that just won't go away. So we have to use then other medications, mood stabilizers or antipsychotics. But all in all, it's a really vast topic. And I know I can't do just it in just a few minutes, but in a nutshell, if you have any of these symptoms, you have a loved one who has gone through this, don't hesitate to seek treatment, because we know there are people out there who are self-medicating with drugs, with alcohol, and there are some who might start experiencing suicidal thoughts, and they might be considering hurting themselves. People do indulge in self-mutilating or self-cutting behavior or self-injurious behavior many times. But we want to do our best to avoid all this. I hope that was helpful and beneficial. Thank you very much, and until next time, thank you.